people, or the reason why some people might not respond to therapies the way that we intend for them to. Okay, so I'm just gonna start off. I have no conflict of interest to disclose. And for today's presentation, I hope that we'll be able to describe the evolution of pharmacy practice as it stands and some of the roles that pharmacists play. Everyone in this room should be able to speak to that, but also to explore some of the potential benefits of pharmacogenomics whilst using patient case examples to do so. And lastly, name some of the resources that you will need to even equip yourselves professionally and also personally if you want to learn more about this, and identify resources that are available to facilitate clinical adoption. So medicine of today, this is what we normally do. A group of patients will come to your institution. We have a set of guidelines, and they always prescribe the same therapy based on what they present with. And that type of practice is known as the trial and error, or the one size fits all. But does one size truly fit everyone? So if you look at the relative efficacy of therapies across the spectrum here, starting from cancer all the way through depression, you can see that we're not doing such a great job. As a matter of fact, for all anti-cancer therapies, only about 25% of them work as intended the first time around. And so we are sort of picking and choosing these therapies and hoping that they will work for every patient that we encounter. And this is seen across many different medical specialties. Also, when you consider the rates of adverse drug events, so we've looked at inefficacies, but let's look at adverse drug events. If you look at the rate of adverse drug events, this is a study that was done in adult patients 65 years and older from 2007 through 2009. And as you can see on the x-axis there's warfarin, insulin, oral antiplatelet agents, oral hypoglycemic agents, analgesics like opioids, digoxin, and some of the meds on the BS criteria are listed down there as the main culprits. But we know that adverse drug events resulted in about 100,000 annual hospitalizations in these groups per year, and also about 166,000 emergency room visits. But what's very interesting here is 4 out of the top 6 classes of medication or medications that are implicated for adverse drug events have pharmacogenetic associations with them. And so that's something that I want you to know. So we know as pharmacists, I don't have to preach to you about this, but drug response is multifactorial. There are many reasons why someone would respond to a therapy, whether you have good kidney function, liver function, your co-medications, comorbidities. These are all very important, but I want you to know, if you don't learn anything else from this presentation today, that your genetics do play a role in how you respond to therapy. So now we are in this era of medical practice. I'm sure you've heard it so many times. Obama calls it precision medicine. Many people call it personalized medicine, individualized therapy. There's so many different ways to name this. But personalized medicine is defined as an emergent practice of medicine that uses an individual's genetic profile to guide decisions made in regard to prevention, to diagnosis, and treatment of disease. And I believe that that's the treatment part, and maybe even so prevention part, that we are here as pharmacists and how we can contribute. So this term, interestingly, was never coined by a medical person. It was first mentioned in the Wall Street Journal in 1999. So it's not a very old term. We all know that it's been sort of like an evolving practice over the last couple of decades there. It's also known as individualized medicine or precision medicine. What I wanted to show you in this graph is just the incidence of the number of articles per year that have included the term personalized medicine, starting from 1999 through the 2000s, and you can see an exponential increase. So it's not something that we can ignore as pharmacists. It's coming, it's here. There are places that are doing this, so we need to be informed as to how we can do it as well. So I showed you the medical status quo, which is patients come in, they get the same therapy. Some respond, some don't, and some may even get side effects. But I want us to think about how we shift that status quo to the medicine of the future, or medicine of today at Mount Sinai, where people are genotyped prior to being given a therapy so that we can select the right therapies for them or the right doses for those individuals. So this brings me to pharmacogenomics. Pharmacogenomics is basically the study of an individual's genes and how it influences their response to therapy. You might hear pharmacogenetics. That's usually based on when you're looking at individual genes, one gene or a set of 2 or 3. But when you think of the entire genome, having the entire genome at our disposal now, since the completion of the Human Genome Project, we have this term pharmacogenomics, because we can access or interrogate the entire genome to find some of these associations. So it's simply a combination of pharmacology and genomics, right? And so that's where pharmacists come in. And there are many potential benefits here. We can improve the utility of existing therapies. We saw that with what our sister just presented in psych. And also we can improve the drug effectiveness and improve safety as well. And mostly what's also important here is we can inform discovery of new drug targets, right? So now that you know that certain individuals are not responding to therapy because they have a certain variant, maybe there could be drug moieties that will target that variant, and that could potentially be a new drug that we can discover. So with pharmacogenomics, we really hope that we can stratify our patients into these 4 main groups. First, the group in green, where the drug, they get the therapy, but you know that it can be potentially toxic for them, or they experience side effects or ADRs. There are also a group that they do not experience any side effects, but the drug doesn't also work for them. And there are also groups that the drug works for them, but they don't experience side effects. But what we really hope for is this group here, where we can stratify who is this drug going to work best for without increasing side effects or minimizing their rate of side effects. So with pharmacogenomics, we are very interested in cytochrome P450 enzymes, and as every pharmacist in this room has probably heard, CYP2 or CYP2C19, 2B6, 2C9, you've heard it before. Many times maybe it brings some horror in your life because you just don't want to talk about drug-drug interactions, but it's important here because we know that these enzymes are mostly responsible for the biosynthesis and the catabolism of endogenous and exogenous compounds, which most medications are. And so they play a huge role in the intensity of therapies that we give to our patients. And there's so many different types of them, but the ones that are mostly responsible for drug metabolism, CYP2D6, CYP2C19, CYP2C9. And lately you also know about CYP3A5. There's 3A4, but we don't talk about 3A4 a lot because it's not highly polymorphic, meaning the genes that encode for 3A4 are fairly conserved across individuals. So we know there's not that much variation there, but when you look at the other ones, there's a lot of variation. So I wanted to quickly take you through this nomenclature. So most of the time you may see genetic reports that will say someone is a CYP2C19 star 1 star 2 or star 2 star 3. What does that mean? And so I just wanted to show you. So simply the CYP, or the cytochrome P450, is the superfamily of that enzyme. The 2 is the family, so that's why we have CYP3 or CYP1A2 or 3A4. So there are different families in there. The C is a subfamily. The 19 happens to be the exact enzyme you're talking about. The star 2 here is the allele, which is mostly the genetic component of that, and we'll see some examples of it. So when it comes to genomic reporting, there are different nomenclatures that are used. So one of them is shown here with the star 2 nomenclature, but the one in parentheses there where it says C681, G, maybe greater sign is what we would say, and then A, it basically means when you're looking at that gene, at the 681st base pair, in the DNA sequence, there are many base pairs. So at the 681st base pair, there's a switch from a G, a guanine, to an adenine, right? And so that's what that greater sign means. So there are different nomenclatures as to how you can represent the same thing. And that particular one means the same thing as CYP2C19*2. Okay. So why is this important to us as pharmacists? Yes, we know there are genetic variations in the CYP enzymes, yes, but how does that apply to pharmacists? So when you look at the FDA database, and throughout FDA and EMA, EMEA in Europe, there are about 1,200 different drug moieties. And when you look at those drugs that have been approved for use in therapy, about 15% of those medications have pharmacogenetic information in their drug label. 15%. So it's not a huge number, but 15% of 1,200 is about 180. But what's also interesting is that out of that 15%, so out of the entire number 1,200, 7% have actionable pharmacogenetic information in their drug label. And actionable meaning that today we can do something about that information in practice. And that corresponds to about 84 medications. So you might say, okay, that's not any, it's only 84 meds, why should I worry about that? But I put it to you that you have to worry about this because those 84 meds correspond to about 18% of all outpatient prescriptions in the United States. They are commonly prescribed medications. So in the US every year, there are about 4 billion outpatient prescriptions. 18% of them are for those 84 meds that have actionable pharmacogenetics. That's about 720 million prescriptions a year in the United States for those 84 medications. So pharmacogenetics is important. As I said earlier, it's pharmacology and genetics. So who is better to lead this discipline if not pharmacists? And we are living in this world where pharmacy practice is changing, I think, over the years. And depending on what state you work in, maybe in the last decade or so, you've seen an increase in our scope of practice, some things with immunization and other things that are happening. But I think that we should just take a look at some of the evolution over the years here. So it started in the 1700s when the first retail pharmacy was opened in Philadelphia, right? The very first one and the first hospital pharmacy all started in Philadelphia. Anyone from Philly here? No Philly, okay. They have too much pharmacy, they don't need more. And so, fast forward to the 1800s, that's when you started, you saw the first licensed pharmacists. As a matter of fact, so I always wonder, so what were they doing in the 1700s if they were not licensed? Go figure. So the first licensed pharmacist was in 1816, and the first college of pharmacy also happened to be in Philadelphia. Anyone went to Philadelphia College of Pharmacy? Okay, no one here today from there. But as you can see, there are a whole number of different pharmacy schools now. I think about 138 the last time I counted that are in the United States now. And I don't know how many in Canada, but maybe we can find out later. And it started also with the APHA. It wasn't called APHA then, it was American Pharmaceutical Association, and then they rebranded to APHA later on. Then you fast forward to 1900s where you have the pharmaceutical, was considered the golden era of pharmacy, right? And so there were so many, everything was booming, drug companies were booming, and the ASHP was also funded around that time. And in 1995, which is not that many years ago, only 9 states allowed pharmacists to immunize. And now all 50 states allow pharmacists to immunize. So we've been, our practice has been evolving over the years. Fast forward to 2000, pharmacists were ranked the #1 best healthcare job by Forbes magazine in 2014. Maybe we should clap for ourselves here. I don't even know if this is the same statistic in 2019, but at least we've been doing something good, right? Over the few years that we've been in practice, and there's so many different community pharmacists, so many types of community pharmacy practices, and even hospital and now industry, academia, research, so many things that a pharmacist can do now. And when you look at the number of pharmacists in the US, and the last statistic was 2017, so about 300,000, about almost 310,000 of us in the United States. So who's a pharmacist today? I just did this quick Google search and I thought it was interesting. And Google tells you pharmacists as providers, we are prescribers, in some states we are leaders, we are patient advocates, we are primary care providers, although CMS doesn't recognize us as such, but hopefully one day we'll get there. We are immunizers, we are medication experts, we are medicine experts, and we are mid-level practitioners. But I think that it's most important to recognize us as the medication experts, and that's why we are relevant to this new course. Also, what is the public's perception of us? And it goes back to the Forbes ranking. We are the most trusted professionals according to the public. Also, we are the most honest and most ethical professionals. Are we really though? Just in this little room, you can tell me if you agree. Maybe if you own your own pharmacy, tell us if you agree with this. We are the most honest and ethical. We are also the most accessible, which is very true. About 95% of all Americans live within 5 miles of a pharmacy. Don't know what that statistic is for a church, but that's also different. Americans go to their community pharmacies very frequently. They usually go there first before even going to a hospital. The same back home. I think it's even more so back home than even here. Most people just go to the pharmacy when they're sick and get all sorts of medications. So according to Douglas Huey, that the trust in pharmacists will only grow as pharmacists continue to adapt to the changing nature of the healthcare delivery system. So there is a need for us to keep up with information. There's a need for us to make sure that we know more than what our patients know, because patients are reading more and more lately. Patients are coming into our hospitals more informed. They know what they're talking about. They come in and tell you, I want Cymbalta. I saw that advertisement on TV and I think I have the same thing. I need this. And they're getting it. Most patients, there is a statistic that as many patients that come in and requesting for something, they get what they request for. And so, patients are getting informed outside, so pharmacists need to keep up with this changing nature of healthcare delivery. And so this concept and also the development in genomics led to a group that came together and came up with these competencies for pharmacists in 2012 for pharmacogenomics. So there were about 10 pharmacy and pharmacy-related organizations that came together and said, let us endorse a set of competencies that pharmacists need to know for pharmacogenomics going forward. And so there were 15 competencies that came up out of this meeting. And they believe that out of those 15, I think I sort of summarized them into these 3. The pharmacists and pharmacy graduates should be able to appreciate genetic influence on drug response, that they should be able to recommend and interpret pharmacogenetic test results, and they should be able to make recommendations based on those test results. And so I hope that today I can at least help you to get over the hump for some examples. Also, the ASHP, or American Society of Health System Pharmacists, they had a statement put out in 2015 on pharmacogenomics, and they also agreed with those competencies. They said every pharmacist should have a basic understanding of pharmacogenomics. They should be able to recommend the tests that are needed. They should be able to design a patient-specific medication regimen for patients. They should be able to educate patients and other healthcare professionals on pharmacogenomics, and as well as communicate pharmacogenetic guided therapy and recommendations to the entire healthcare team. So not only did they make us the ones that implement it clinically, but they also stated that we should be the educators of this field. So what they said, and I just want to quote the statement from them, that ASHP believes that pharmacists have a responsibility to take a prominent role in the clinical application of pharmacogenomics. This emerging science should be spearheaded by, in many institutions, by pharmacists to promote safe, effective, and cost-efficient medication practices. So for us to do this, I want us to take a look at some patient examples and learn how we can apply some of this information. So first, I want to talk to you about simvastatin and SLC1B1. We know simvastatin is a very commonly used medication, and so let's take a look at the patient first. So this first patient, AM, she is a 66-year-old white female. She presents to the emergency room with chief complaint of pain in her left thigh and knee. She said it's been going on for about three days. She says that the pain is probably due to her new Zumba class that she started, and she thinks she's just sore from the Zumba. Her past medical history is significant for diabetes, hyperlipidemia, and hypertension. She's on metformin, valsartan, simvastatin, gifrobrazole, and her physical exam upon presentation was unremarkable. Her labs were all normal. She's treated with analgesics, and she's discharged home. Just think of that patient for a minute. So first, I want to talk about statin-induced myopathy. So there are types of myopathy, especially when it's statin-induced. The first one is the mild myalgias that you might see, and there's no increase in creatine kinase with these myalgias. And then it progresses into myositis, which is only about 0.5% of patients. The most common ones are the myalgias that are about 2 to 11%. As a matter of fact, this is even higher in practice than what's reported in the label, because in practice we see a lot of patients complaining of pain, muscle pain with statins. And finally, there's also that rhabdomyolysis, which is even more marked elevations in the creatine kinase levels, muscle damage. It comes with acute renal failure, and this is a very, very small percentage of the population. The main consequence of these myalgias is the discontinuation of the medication. And statins are very effective meds, so if you can preserve them, it's best that you do so. And there's some clinical factors as well that would increase your risk for these myopathy. First is your age, older age, females, BMI, high dose of the statins, if you have a reduced clearance due to hepatic or renal failure. Also, drug interactions, 3A4 inhibitors tend to be a big one here, fibric acid derivatives as well. And so these are all some things that as pharmacists that we can keep in mind and help to best tailor the therapies for our patients. But when it comes to the genetic influence, there's a gene called SLC1B1. And this gene, it's actually codes for the carrier organic transporter that transports statins from the blood into the liver. And so this transporter gene, if you do have a variant in this gene, as I showed earlier, the most common variant here is 521T2C, and it also has a different RX number. RX numbers are, it's called the reference SNP ID, that's RX. And so here, the number here is 4149056. No one really says that in practice. You just see it on your reports. But most of the time, you call it the star or star 15, star 5, star 17 in the SLC1B1. So here, the changes at the 521st base pair, there's a change from a thymine to a cytosine, right? And so it has a unique identifier. It's every variant ever known to man has a unique ID code. And so for this ID is 4149056. And so wherever you put this ID in the SNP database, you will see this one come up. So this particular variant is found in anyone that carries a star 5, anyone that carries a star 15, anyone that carries a star 17. And so when this variant is in your gene for SLC1B1, the transporter has reduced activity. So now you're not transporting more of the statins into the liver for clearance. So more of it stays in the blood and causes the muscle pain because it gets to go to other parts of your body and then cause the muscle pain. So if you carry this variant, you have an increased risk for the statin-induced myopathy. I think I went a bit ahead of myself, but it's saying the same thing here. So what I wanted to show you is this table here, and can you see the cursor? No. All right, so most individuals happen to be the TT variant, meaning they have 2 copies of the normal base pairs at that particular loci in the genotype. So they tend to be homozygous wild type carriers. So those are TT, and that's up to about 80% or 88% of the population, depending on the makeup of that population. Because another thing to also realize is these genetic variations tend to be more predominant in certain racial ethnic groups than some others. So depending on the makeup of the population, it can go all the way to about 80% have the normal. But then there are those that carry the TC or the CC variant, and so those individuals would have reduced function. So if you carry one, you have reduced, but if you carry those 2 as a CC, then you have markedly reduced, or you're considered a poor function, and the intermediate functions carry just 1 allele of this. Okay, so thinking this might be too small, but you have it on your phones as well. What I wanted to show here was just a meta-analysis that looked at all the studies that were investigating the association between SLC01B1 genotype and statin-induced myopathy. And what they did here was look at 7 different studies that studied different statins, looked at patients' genotypes and also the resultant myopathy. And I'm just gonna highlight some of the things here. So when they looked at any statin, they realized that, I wish I could help on there, but in the very first graph, there is one? Oh, thank you. Oh, it doesn't work. It's okay, I could talk through it. So the A, when you look at any statin, when you looked at the statin, they realized that I wish I had it. This doesn't work. Okay. But it was most significant, the association was most significant for simvastatin than any of the other statins, and that's why, my screen is really big, so I don't want it to. That's why we talk about simvastatin to be the most prominent association there after combining the results from all the 7 studies. I just want to quickly go back to it. If you look at atorvastatin on this side, you see that the association was not significant because it crossed that 1 mark there when they combined all the studies that looked at atorvastatin. So we know this association is clinically relevant, especially for simvastatin. And this was represented in a different table here, so I'll probably use this one first. So when they looked at all the statins combined for severe myopathy, they saw an association for those that were C allele carriers had about a 4.4% more risk, or times 4.4 times more risk than those that were normal carriers. When you looked at simvastatin alone, this association was significant, especially for those that were on simvastatin 40 milligrams or more. And that association was statistically significant. When they looked at it for severe myopathy, they also found the association to be significant for those on 40 milligrams of simvastatin or more. Atorvastatin rates were not significant at all. Okay, so this led the FDA to, there was a point that they recommended against the use of 80 milligrams of simvastatin. I don't remember how many years ago, but it was not too long ago. They recommended against the use of 80 milligrams because in those studies, what was found was that even those that were normal, they carried the normal genotypes, if they were on 80 milligrams, they had a higher risk for myopathy. So the FDA said, okay, no one should be given 80 milligrams of simvastatin. However, those that were on the 40 milligram, which tends to be, I think, the most common dose that I've seen with simvastatin, the genotype played a major role in whether you ended up with myopathy or not. And so what the CPIC guideline, or Clinical Pharmacogenetics Implementation Consortium guideline, recommends is those that carry at least one copy of the C allele, that you shouldn't use simvastatin 40 milligrams in these individuals. You should at least switch to a lower dose or choose an alternative statin. So switch to a lower dose or an alternative statin. Most of the time, a lower dose might not be that option, especially if they have not been optimal at 40 milligrams. It doesn't make sense to go back to 20. So choosing an alternative statin would be the best way to go. So remember that patient we talked about earlier. So she presents back in the hospital about a month later, and she's complaining now there's very severe pain in her left thigh. Upon physical exam, the doctors realized that she has mild muscle wasting and tenderness over the left mid quadriceps, right? She was, you know that in your hospital you started a pilot program for simvastatin and SLC1B1 testing. The lab values come back and her CK level is at 5,865. The normal range is 25 to 175. Wow. So she has markedly elevated CK here. And so we know a patient has been diagnosed with statin-induced myopathy at this point. But I want us to review some of the questions that I have here, and I think they are the same questions for your CE, so hey, we'll just go through the answers. So based upon the patient's clinical presentation, could this patient be a TT or normal function, true or false?
Can you remind us what the dose of her simvastatin was?
It was 40 milligrams.
And false.
Then you said false. Do we all agree with false?
I think true.
You think it's true? Okay, so someone tell me why they think it's false. Someone tell me why they think it's true. So the patient came back and she's diagnosed with statin-induced myopathy. Can this patient be a normal metabolizer or normal function carrier?
No.
So everyone thinks it's false? Okay.
Well, if you want to go back to the patient case.
Mm-hmm. This one or the first one?
The first one.
Okay. Oh, I'm moving, but I got you. This one.
Right. The patient is on gemfibrozil. The patient is also on a calcium channel block. So that's why I say it's true.
Good. Okay. You're a true pharmacist. I was hoping someone would catch that. But because of her elevated CK and how much of the elevation, it's mostly a genetic component as well. So yes, you are right, and we'll talk about that in a few. But she's possibly not a normal. She could be an intermediate or a poor function at this point. But I said I'll come back to that. So let's look at some of these questions. So the patient's genotype is reported as a star 5, star 15. Do we remember what that means? Bird is like. So star 5, star 15. So what is her phenotype? And I'm just gonna go back to that chart, although you have it. So this